textbook of family medicine defining and examining the discipline, and co-author of Healthcare and Spirituality. His talk today is Health Reform in America, Lessons Learned from the Oregon Health Plan. Thank you, Dr. Saultz.
Well, thank you. It is an honor for me to be here with you today and to talk about what we've learned over the 22 years that I've been in Oregon with regards to healthcare reform. I will tell you at the outset that my presentation about this is perhaps a more personal one than you might think, because this is not something that I've studied. It's a story about something that I've lived through, really from the start to the end of this experiment called the Oregon Health Plan. Now, I'd be interested in knowing, before I put up my goals and the rest of my slides, how many of you know what I'm talking about when I say the Oregon Health Plan? And how many of you have really not heard that term before? So there's a few of you that haven't heard it. There's lots of you that have. If we had been here talking about this 10 years ago, probably most everybody at an ethics talk would know what the Oregon Health Plan was, because it was being talked about a lot then. And it's a little bit fallen off the radar screen for reasons that I think will be clear as we go on. This is a picture of the Wallowa Mountains up in northeast Oregon. It's near a community that we send all of our residents to for a rotation site. And because this really was about a plan to get health care to all Oregonians, it's kind of appropriate that I show you this picture from the eastern half of the state, where the population is pretty sparse. It's not easy to get care to those people for just purely geographical reasons. There we go. So I've got several goals I want to go over today, and to make this timely as opposed to just a history lesson for you, I'm going to talk about what I think are the 6 primary important questions to be answered before we can proceed with reforming the healthcare system. It is a source of great frustration to me that we're in love with 1 or 2 of these questions and we never want to talk about the others. And I'm going to try to be systematic about why all 6 go together and how I see them fitting together, because I hope that the Oregon Health Plan and the story that I'm going to tell you can be both a cautionary tale and a guide for what we may do now that we're talking about reforming the healthcare system again. Okay? Second, I want to explain why defining a basic benefit package is among these 6 important questions. That you cannot talk about who's going to pay for health care until you talk about what we're going to cover. And that unwillingness to embrace a discussion about that is one of the biggest barriers we've got to overcome if we're going to do reform. Third, to talk about how Oregon defined the basic benefits that we considered the package for the Oregon Health Plan, the process of doing that, to talk a little bit about what we learned about what worked and what didn't work. And I think for an audience interested in medical ethics, this was an ethical conundrum of the first order to figure out how to work through this. And finally, to share the lessons that I think can be learned from the things we did wrong. So both the things we did right and the reason why I think the plan got in trouble and why it doesn't exist in the form that you probably remember reading about it in anymore. So, what are these 6 important questions? And this would be, I think we could have an interesting discussion. We'll have plenty of time for discussion at the end of this about whether my 6 questions are the right 6 questions or not. But I think that they're a good 6 questions, and I'm the speaker, so I get to say what I think they are. And then we could debate whether there's a 7th one or whether one of them is redundant. Question number 1 is, what are the primary goals of the healthcare system? Is the goal to provide a basic level of care to everyone? Is it to provide a certain level of health to the population? Is it to provide access to certain kinds of services for individuals? Is the goal of the healthcare system to sell health care to sick people at a profit? Okay, what's the paradigm around which we define that goal? The second is the question we're going to be focusing on today. What is a basic level of benefits that we should provide to everybody? Now, do we have a basic level of benefit that we provide to everybody in America today? Answer is yes, we do. We have laws in America that prohibit emergency departments from turning people away. So it is a basic benefit that if you go to the ER, they can't turn you away. We do not have a benefit package based on services, but based a little bit more on where you go, right? So we have EMTALA, and we have a basic benefit package that includes being at least assessed in the emergency department. That's about all the more sophisticated it is, I might add. But we do have some basic benefits. Third, what mechanism will we use to ensure quality and value? And what outcomes matter to us? This is how do we organize the delivery system in such a way that we get what we pay for, that we get our money's worth, okay? I think the fourth question is, how will the system manage cost? Because everybody's worried about cost. Business is worried about it because of the benefit cost of providing coverage to their employees. Government is worried about it because of the unaffordability of the Medicare trust fund as the baby boom ages and health care costs aren't controlled. Patients are worried about it because more of this cost is being passed on to them now in the form of deductibles and co-pays and premium shares and the like. Interestingly enough, the group that almost singularly is unworried about this is doctors and hospitals. Not nearly worried enough about why the ground is sort of moving underneath of us. And it's moving underneath of us because everybody is really worried about this and trying to figure out what to do about it. The fifth question is, what's the proper balance between social insurance and free market consumerism? In other words, how much of health care is a community benefit and how much of it's a personal benefit? And is that discussion in any way informative to us about how much the responsibility for this ought to be at the individual level versus at the societal level or the state level or the community level or whatnot? And the sixth question is, what portion of cost should be borne by the government, what portion by business, and what point by individuals? Okay? Now, I find that most political discussions about health reform are in love with question 6. They want to have arguments about question 6 without much regard for 1 through 5. But talking about question 6 before you talk about 1 through 5 is like you and I negotiating about going out to dinner tonight and me wanting to decide who's going to pay for dinner before we decide where we're going. Okay, well, you know, I might be a lot more interested if I'm going to go to a really inexpensive restaurant in paying, but I may not want to pay if we're going to a really expensive one. And this is the problem that government and business has right now. They don't have any confidence that cost will be dealt with. Okay? So think about these. Now, what I want to point out to you, again, we could disagree about questions, but these two questions are questions that need to be addressed at a societal level. They're cultural questions. They're questions that communities need to struggle with, or that the nation needs to struggle with, or that political bodies are, you know, this is not something that doctors can necessarily decide. This set of questions really relate to the delivery system, I think. They relate to how do we deliver value, how do we know what value is, how do we manage cost, and how do we ensure quality. And I think that's really how do we organize the way doctors and hospitals and pharmacies and other parts of the healthcare system work together to make care happen. I think our attention as health providers should largely be about questions 3 and 4, and then 5 and 6 are financial questions, aren't they? They're really about how the costs are divvied up and who pays the bill. And so you can think about it that way if you want, and maybe that's sort of instructive. When I talk to lay audiences, I think they can get their mind around these 6 questions. Today we're going to be talking about question number 2. What did Oregon do in the early 1990s that was creative and innovative and newsworthy with regards to how we defined a basic level of benefits for everybody in our state? Okay, so today's discussion is all about question 2. And if you're interested in the other 5, well, that's for another day. Okay? All right. So I moved to Oregon in 1986 to become the family medicine residency director. We were coming out of the recession of the early 80s, which was a particularly bad recession in Oregon. And it was a very difficult economic time in the state because there were a lot of environmental constraints being placed on the timber industry. In Oregon in the 1970s, the economy was mostly trees and fish. We cut down trees and turned them into wood, and we caught fish and sold them to people who liked to eat salmon. Okay? What happened to us in the 80s was the spotted owl controversy. The spotted owl was listed as an endangered species, and there was great restrictions placed on what timber could be cut, and the economy was going through a lot of challenges because of that. Coming out of that recession, the Medicaid program was pretty parsimonious in terms of who was covered and what was covered. People over 65 in Oregon in 1988 were covered by Medicare, just like they are today. Most employed people had employer-based health insurance. The cutoff for Medicaid eligibility for general assistance people was at 53% of the federal poverty level. Now, I'm going to assume a certain understanding about Medicaid. But you know the federal poverty level isn't very much money, and if you were 54% of the federal poverty level, you were deemed too wealthy in Oregon to get Medicaid benefits in 1988. And about 18% of adults and about 10% of children were uninsured at that time. And there were challenges around whether Medicaid would be paying for transplants. There was a little boy with leukemia. Bone marrow transplant was relatively new. The Medicaid program decided not to cover that as a benefit because it was an experimental therapy, and there was a lot of discussion about how many well children could receive vaccinations for the cost of a single transplant in this child, and there was a lot of ruminating around about what good use of public funds were. And so in this environment, a group called Oregon Health Decisions, which was a community nonprofit that was looking at health system issues, primarily in an ethical framework, I might add, came up with this idea that then caught on with a group of legislators to create the Oregon Health Plan. So it was passed into law in 1989, and we then spent 5 years getting a waiver from the federal government to give us permission to do it. During that 5-year period, we had the 1992 election that elected Bill Clinton to be president, and you'll remember that the Clintons came to Washington trying to reform health care and give everybody a card and have universal coverage. And of course, during the middle of that presidential debate between the first George Bush and Bill Clinton, it was impossible to get Medicaid waivers because everybody was trying to figure out whether Medicaid was even going to still exist if there was a Clinton health plan. Does this make sense? So the idea of the plan was to have 3 components, and by implementing all 3 of these components to achieve universal coverage in our state, or near universal coverage in our state. The first component was to expand Medicaid up to 100% of poverty. That was going to bring 300,000 new people into the Medicaid program. The second was to require employers to provide coverage for their employees, an employer mandate. And the third was to create a high-risk pool for people who had uninsurable prior conditions. Does this make sense? The state would fund that, which would allow people to get insurance. And then the state would contract with managed care plans, both insurance companies and provider-owned managed care entities, health systems or hospitals or physician groups that would engage in risk contracting with the state to take care of this Oregon Health Plan population. So it was a 3-part idea to do that. Secondly, the plan intended to explicitly ration services by deciding what basic health care included and requiring all the plans in the state to deliver at least that level of service. Okay? That it would utilize capitated managed care, and the mechanism that they came up with was that there would be a group of people called the Oregon Health Services Commission. These people would be completely separate and independent from the legislature. They would be tasked to rank every service that a person could receive from the healthcare system and rank them in diagnosis treatment pairs. So there could be osteoarthritis of the hip, non-steroidal anti-inflammatory drugs. There could be osteoarthritis of the hip, joint replacement surgery. Okay? All of these things were to be ranked in order from the one that was the most important to the one that was least important. Then an actuary would say, if we took care of everyone in the state with this problem, using this treatment, what would the dollar expenditure cost of that be over the course of a year? And actuaries do this, you know. They decide if this many people are in a life insurance policy, how many of them are going to keel over in a year, how much will we have to pay out, and what premiums should we charge them all so that we make money at this. Okay? So they would then put a cost to each service. Then the legislature, when they decided how much to put into the Medicaid program, would have to start at the top of the list and move down. You could not fund the item on line 100 unless you funded lines 1 through 99. Okay? So however much money they put into the program would decide how far down on the list we would go. And if they wanted to fund things down to a certain level, they had to buy all the things that were above that. And the legislature could not change the order of the diagnosis treatment pairs. That was the Health Services Commission's job. So you understand the basic approach to how that was to be done. So this Health Services Commission was a group of people appointed by the governor. There were 5 physicians. I will say that 2 of the 5 were family physicians. The chairman of OBGYN at the university was the first chair of the Health Services Commission. There was a public health nurse, a social worker, 4 purchasers or consumers, and it was staffed by a newly created Office of Health Plan Policy and Research, which is a health policy office in state government that reports directly to the governor. Okay, that still exists today. I will tell you that today, everyone who works in the Office of Health Plan and Policy and Research in Salem is a faculty member in my department. So we are very connected with state government, and we're really involved in real health policy, as opposed to just health policy research, which we're very involved in too. And you have to keep these things separate, because believe me, real health policy is very unacademic and illogical. And real health policy research needs to be kept away from that a little bit if you want the research to be unbiased. Does this make sense? But anyway, this was the Health Services Commission. Now, the first thing they did was they got advice from some consultants who advised them to use this formula, and this was the real formula, based on cost effectiveness of a particular service. Now, I put this formula up here because it's almost impossible to understand, but being a math major undergrad, I love things with sigmas in it, and I love to watch people's faces when you show them crap like this. Okay, so I'm having fun with you now. But the idea was that they wanted to use a cost-benefit method of ranking the diagnosis treatment pairs. Okay, now, how many of you think that sounds like a reasonable approach? Well, yeah, a reflexive, well, you'd like to do things that are worth the most value. It was not like it was a method that was as good as any other method you might come up with, and so they started plugging things in. Well, the first list they came up with was ridiculous. It had repair of an ingrown toenail above an appendectomy, because it turns out that it costs very little to do an ingrown toenail, and it works 100% of the time. And although appendectomies save lives, that was more costly. And of course, the New York Times actually covered the first list. It was a headline in the New York Times that Oregon thinks that ingrown toenails are more important than appendectomies and that this is a ridiculous process. There were ethicists who took objection to the notion that we were doing this. There was an enormous amount of sensitivity from the community of people who advocate for uninsured and Medicaid patients. Because if Oregon does this and we cover these 300,000 people, but we redefine the benefit package downward, we are taking services away from people who are already in Medicaid, aren't we? And so one of the big congressional opponents of this was Henry Waxman, who represents a poor district in Los Angeles, and he thought this was the first step towards dumbing down the comprehensiveness of the Medicaid program. Okay, and so this was a gigantic failure. It produced a list that didn't meet even the basic sense of just common sense of what ought to go where on this list. So they threw it all away and they went to Plan 2. Now in Plan 2, they defined 17 categories into which every diagnosis treatment pair would exist. And they ranked the categories first, and then they ranked the items within the category. So these are categories 1 through 9 on their prioritized list. And of course, there are value judgments in all of this. They heard public testimony, they heard testimony from healthcare providers and from government leaders, and they decided that acute fatal conditions where care resulted in complete recovery, like an appendectomy, ought to be at the top of the list. Okay? And then they moved down the list with all these other things. These were items 1 through 9, and these were items 10 through 17. Right? And then things were put into these categories and ranked within the category was the method that they ended up using in round 2 of this process. They then took the list that they created out and they showed it to the public. It was published. It was sent out. The highlights of it were in the newspaper, and it was published in a report that went to both the government and to the public. They held public hearings all over Oregon. One of the things that was criticized about the Oregon Health Plan, well, were these hearings really open? Were there as many disabled people or poor people or people who didn't speak English who came to the hearings? Did people understand what was being discussed or not? They held public hearings all over the state in every county. They did move diagnosis treatment pairs by hand sometimes. In other words, they listened to testimony. People said, well, taking care of kids with cystic fibrosis, we think you got that in the wrong category. That ought to be higher than it is, and so it got moved. And the coverage decisions, so the plan was we're going to have this list. We're going to tell the health plans when the state contracts with them that you have to cover down to this item. But then the health plan could cover things farther down if they wanted. We found out early on that if somebody comes in and they have a wart on their elbow, treatment of warts was below the line. Why wouldn't you just go ahead and zap the wart anyway if you're a primary care doctor? It makes patients happy and it doesn't cost that much. So a lot of warts got zapped even though they were below the line. That would be the same thing as providing a service to a person who is uninsured and doesn't pay you. You're just providing a service to a person who's on the Oregon Health Plan that isn't covered by the plan, and you could get the patient to sign something and charge them, or you could just freeze the wart. Okay, so there was a way to do services and bill people directly if you needed to do that. There needed to be an appeals process at the level of the health plan and at the level of the state, and so there was an elaborate appeals process if somebody objected. Okay. Fairly immediately, we got into trouble with the Americans with Disabilities Act because they objected to the fact that some of the care for disabled people they thought was ranked lower than it should be because the commission had put less value on their role in society. Okay? And so there was a whole lot of rethinking the list and a bunch of things that got moved because of objections that could have led to a lawsuit from the Americans with Disabilities Act. And so we had to kind of go back and retool. That took about 6 more months to get that done. But in general, you have an idea about the process. And most of the way this would have played out in the ethics community nationally was Oregon is rationing services. They're deciding to cover everybody with this list down to the line and to not cover things below that instead of leaving people uncovered. And there was, I think, quite a lot of excitement and interest and support for the idea of doing that. At least I heard from a lot more people who thought the idea was important and worth doing than from people who were objecting to it in one way or the other. It was not very easy. You know, people who objected to it, the question you'd ask is, so what should we do instead? Continue to have 300,000 people that arbitrarily get nothing? On what foundation is that okay? But you get the idea of the way the process sort of worked here. Okay, so on February 1st, 1994, interestingly enough, 15 years almost to the day, okay, the Oregon Health Plan began, and the cutoff line of 754 total items was between line 565 and 566. So that means if you had had a mastectomy, a reconstruction of the breast after a mastectomy was one line below the line, was one step below the line. It was not covered by the Oregon Health Plan. Orthotics for flat feet was not covered by the Oregon Health Plan. But peripheral neuroplasties of like a carpal tunnel release was above the line. Okay? That's where the line happened to fall based on what the legislature was funding in 1994. And then this was capitated out to the health plans. Now, my personal role in all of this, I was the residency director in family medicine between 1986 and 1994. And in 1993, when it was clear that this was going to achieve its waiver, it would have been about the summer of '93, the university decided to form its own non-for-profit Medicaid HMO with county government in the largest, the county that makes up most of metropolitan Portland. This was going to have 150,000 or so enrolled members in it. It was going to be in a full risk contract with the state. The university agreed to take the hospital risk. County government was going to take the rest of the risk. The university was going to name the medical director, and the county was going to name the plan administrator. And so a woman named Mary Lou Henrich from Multnomah County was the plan administrator, and the university asked me to be the medical director of this new health plan, which we called Care Oregon. I decided to do that for 6 months on a leave of absence from my job as residency director because I thought capitated managed care was going to be the way everything was reorganized under the Clintons or whatever system. I thought that was going to be the future. I knew nothing about it, and I felt completely unable to teach my residents anything about it. So I went down and we worked on this, and literally 2 of us started this health plan, which today is the largest non-for-profit Medicaid plan in the state of Oregon. Okay, it takes up 3 floors of a building down there, and I'm not sure, I don't wish that I had killed it in its infancy. but at any rate, that's a subject for another day. At any rate, that's where the cutoff line was, and so we were then trying to figure out how to actually manage this. And I've got stories to tell you about that when we get to our discussion if you want to hear them. What are the things that I think we accomplished with the Oregon Health Plan? What are the things that I think, looking back at this, I am proud of? Well, first, I'm proud that we immediately covered 130,000 people that had nothing before. That may sound like an abstract statistic to you, but I was practicing family medicine a quarter of my time at that time in one of the university's clinics, and I saw people cry in my office because they hadn't been able to see a doctor. And this was now provided to them. And I had people that moved into the state from across the border in Washington in order to have this coverage. It really affected people's lives, and they were 130,000 real people that had names and faces and families. Okay? And I think that's one of the problems we get into sometimes when health policy becomes so divorced from clinical practice. You look at 130,000 and you just make a number of that. Okay, as opposed to 130,000 stories. Secondly, there is excellent data that emergency department utilization statewide dropped by 20% in the first 18 months of the Oregon Health Plan. And it stayed down as long as the plan was functional. So this was not a good thing if you're running an emergency department, but it was a really good thing in terms of decongesting the emergency care system for people who had emergencies and for managing health care costs. We rapidly introduced managed care to the state, and actually I think that created a bunch of problems, but it also created some positive change in the practice environment regarding how people thought about quality and how people thought about cost management in different ways. I think it achieved national and international recognition. I can come 15 years later to Louisville, Kentucky, and have the majority of people in this room having heard of it. So there's something to be said for that. My university, my department, it did not hurt our reputations that we were in a place doing something like this. Okay? That at least, by golly, we were trying. And I could say to a lot of people who maybe didn't like parts of this, well, at least we're trying something. What are y'all trying where you are? Okay? So, and so we were proud of that. And it reduced the number of uninsured from 18% to 8% of the adults. And in Metro Portland, and so a lot of those 8% were people who lived out in the hinterlands of the state and who didn't sign up for the Oregon Health Plan unless they happened to get sick. And so they were citizens, but they weren't sick and they didn't sign up, and there was 8% of them. But in Portland, we got down to under 3%. At one point in time, Mary Lou and I felt that we might actually be able to produce a list of people in the city, a list of names of uninsured people, by taking the Oregon Health Plan and the health plan rosters and subtracting it from the census data, that we actually might be able to start ticking them off one by one, and maybe we'll get rid of all of them. Maybe every single person in the city could be covered. We actually were thinking about that along about early 1995. Okay? What are the things that were failures? Like, don't try this again. I would recommend against it. You know, do not objects in the mirror appear larger than they do in real life. Well, first of all, the employer mandate was never implemented. The state never even seriously sought the necessary ERISA waiver. Do you guys know what ERISA is? Is there any of you who do not know what ERISA is? Okay, so ERISA is a federal law that prohibits the states from regulating benefit packages of companies. And the reason is because if you're General Motors and every state has a different rule about what the retirement plan or the health plan of your employees ought to be, then it's impossible to have a single plan. And so ERISA is a federal law, and to do an employer mandate, you have to have an ERISA waiver. Oregon didn't even pursue that. Now, I will tell you that that broke faith with me and with all of the hardcore advocates of the Oregon Health Plan, because this was never supposed to be a Medicaid experiment. This was supposed to be a universal coverage scheme. It was a bait and switch of the first order when they didn't really pursue this. And I really believe there was a wink and a handshake under the table between Associated Oregon Industries and state government to not seriously go after that waiver. But the provider community all bought into this because it wasn't an experiment about rationing care to the poor. It was defining basic benefits for everybody in Oregon. That's a whole different ballgame. So when you've had that kind of bait and switch happen to you, you're way more skeptical the next time some wise guy in Salem wants to talk about health care reform. And that's one of our problems right now. The provider community is not that interested in listening to great ideas because they're not sure they have a reliable partner in state government. Okay? Oops. Secondly, there was this overall catastrophic failure of capitated managed care. I do not know whether capitated managed care is dead in Louisville, Kentucky or not. In Portland, Oregon, it literally does not exist anymore. Everybody is in a preferred provider organization or a high deductible health plan or something. Managed care died out there, and it was killed mostly because of its own greed and because in the end they were cream skimmed by the high deductible health plans in terms of cost competition for benefits, and that's another subject for another day too. The biggest failure of the Oregon Health Plan is it did not control health care costs. It passed the responsibility of that on to these plans, and the plans were all separate plans. And the problem if you've got 15 or 20 different health plans is the providers won't really listen to any of them very much because, well, what the heck, it's only 12% of my practice. You can just go take a hike and I'll take care of the others. So it did not control cost, even though it was supposed to pass along risk to do that. There was an erosion of universal coverage because of the items up higher on that list. People didn't sign up, and the employer mandate didn't happen, and the whole vision of universal coverage, we probably were 18 months into the Oregon Health Plan before it was clear we weren't going to get close to that. There were cuts to provider reimbursement that was really the ultimate, a major ultimate cause of the demise of the plan. Let me tell you a little bit about that. So the day the Oregon Health Plan rolled out in Portland, primary care practices were being paid an effective reimbursement rate of $40 per relative value unit. That was based on capitated payment, but our practices at the university were realizing $40 per relative value unit. Does everybody know about the resource-based relative value scale? I need
Explain that.
I need to explain that. Okay, so most health plan contracts today are based on a 1986 paper that created something called the resource-based relative value scale. The government, the Medicare program, this was created for Medicare, defines a relative value unit assignment for every service that can be provided by a doctor to a patient. And this is about physician payment, not hospital payment, okay? So an office visit may have a relative value of 1 unit. Delivering a baby might have a relative value of 14 units. Doing a heart bypass operation might have a relative value of 28 units. Those are actually about in the range of what they really are. And then when you do a contract, you contract for $40 per RVU. So if it's worth 1 relative value, you get 40 times 1. If it's worth 14, you get 40 times 14. But commercial health insurance in Portland, Blue Cross and Blue Shield was paying my practice $43 per RVU. Medicare was paying me $38, and Medicaid, the Oregon Health Plan, was paying me $40. Now, if you're running a practice, and this is the payment structure, you don't care who your patients are. You're paid pretty much the same no matter what, right? This is where it was in 2000, and this is where it was in 2007. Notice, and these are not inflation-adjusted dollars. Okay, I'm not inflation adjusting. We're actually paid $6 less to care for, to provide 1 RVU of service to a Medicaid patient 13 years later than we were in 1994. Now, what do you suppose happens when you go from this to this? Well, you have 2 things that you can do. Number 1, you can stop seeing all of these people, in which case this matches this pretty well. When you factor in inflation, we can live with that, okay? And so you have a lot of primary care practices that won't take new Medicare. What does no new Medicare mean? It means if you're already in my practice and you retire and you turn 65, I'll keep you. But if you just moved into town, I don't want any more Medicare patients at $36 per RVU. Or you can say, I'm going to take care of everybody regardless of who comes in, but then the kill zone is the ratio of these people to these people. You can decide to have a cost structure that's set up here, in which case you have a pretty ugly office that's very cramped and very few staff, and the phone doesn't get answered very well, and these people won't come. Or you can have a cost structure that's up here, in which case you can't afford to take care of very many of these people, and you have to ration how many you'll see per month. This is what's happened in primary care all over the country, and it happened in Oregon. Okay? So very quickly, by 1996, doctors were already jumping out because that rate declined instead of going up over time. You with me? And it affected access. And here is the August 27th Sunday Oregonian. It's a piece that was printed about the town of Brookings. Brookings is a fishing village on the southern Oregon coast down by the California border. This is an article that says it may take a legislative act to persuade doctors in this community to treat Oregon Health Plan patients. At least that's what one doctor says, and it goes on. It says, Dr. Larry Witt, who recently stopped taking new Oregon Health Plan patients, said it's unlikely to get Brookings area's doctors would get together and share the load. Now what this story, Dr. Witt is a family doctor, and it's a story because he was the last doctor in Brookings to stop taking Medicaid. I teach an ethics class with students about ethical ramifications of practice management decisions, and I always love to ask them this question. Why in God's name did the last guy to quit get his name in the paper instead of the first guy to quit? Because Larry Witt was the hero who hung out the longest, and by the time he quit, all of his frickin' patients were Medicaid because he was overrun with them. Does this make sense? Okay, so we've got to teach our students about, and of course this is the gynecologist down there who talking about having 2 levels of care is immoral in his view. Okay, I mean, this was right in the newspaper. But it was a collapsing access to care for the Oregon Health Plan patients. Now, we made some observations that are off the record, and we have not written about this because they're simply hypotheses, and I'm not sure I could prove them to you. The Oregon Health Plan held together in towns that had only one hospital. The Oregon Health Plan collapsed most quickly in towns with more than one. Why do you think that is? The answer is because if there's more than one hospital in town, they all engage in schemes to chase the poor to the other one. But if there's only one hospital in town, they might as well suck it up. These patients are either going to be seen by the doctors or they're going to overload our emergency department. We better get our medical staff together and solve this problem because we're screwed if we don't. But they have the illusion that it's someone else's problem when there's more than one of them. Now, and I've had meetings with the hospital administrators and medical staffs in these hospitals, and they will admit this is true. They just can't figure out, like the prisoner's dilemma, how to not keep acting that way. You with me? So I think you can see this is an appropriate topic for an ethics discussion. It's not a stretch. Okay. So in 2002, we had a big recession like the rest of the country, but in Oregon the recession was incredibly ugly for a couple of reasons. The same reason why this recession is particularly ugly. Now it's not really timber and fish anymore. Now we've got a lot of Silicon Valley. We've got Intel and Fujitsu and floating point software and Mentor graphics. It turns out that the two things you need to really make high-end computer equipment are water and electricity, and we have massive amounts of water and almost free electricity because of the dams on the Columbia River. So it's a great place to build computer chips, and Intel's all over the place there. But Oregon does not have a sales tax. We have a property tax that's constitutionally limited and cannot be raised, and we have an income tax, which is the most volatile kind of tax in a recession. So this recession in 2002 was so bad that we laid off half of the state highway patrol. We closed all the schools, and they had to operate on a 4-day school week for 6 months at the end of that year. County courthouses only operated Mondays through Thursdays. There was no way to pay for the Oregon Health Plan. And so, but they didn't want to not cover these people because they had put into the law in '89 that everybody below 100% of poverty has to stay on Medicaid. Their waiver limited how far they could move the line up. There was nothing they could really do. So they separated out. If you're below 53% of poverty, you keep the Oregon Health Plan. If you're between 53 and 100%, you get the OHP standard. And the OHP standard paid for inpatient services first, followed by physician services, followed by pharmacy benefits, and we took away everybody's mental health drugs. Now there's a plan to save money, okay? There's a plan to save money. It's really wonderful. We had a bunch of people in Portland that were shot by the police. A lot of these people, so this was a huge cost shift from the Medicaid program to the criminal justice system because they ended up in jail. So, you know, it's like squeezing Jell-O when you try to manage Medicaid costs. It tends to come out of your fist no matter one direction or the other, okay? So what are the lessons learned from the Oregon Health Plan, the take-home stuff? First of all, cost-effective analysis is a bad way to define basic benefits. I think we pretty well proved that that's a bad idea and you shouldn't do it. Okay, it's not just based on cost-benefit. There's much more value and cultural and community-based stuff that factors in. I think our prioritization process achieved widespread public and professional acceptance. The people of Oregon were proud of this. The patients were basically satisfied and happy with it. There were no more complaints about it than there are complaints about anything else that happens in the healthcare system. And I think doctors and hospitals thought that the prioritized ranking system worked. So I think that worked for us. Whether it would work in Kentucky or not, I don't know. We're a relatively homogeneous state, and everybody out there is pretty egalitarian about being willing to try things. They have all either made the decision to drive all the way across the country to move there, or they're descendants of people who did. I get asked a lot, having grown up in Ohio, what the cultural difference is between Oregon and Ohio. After all, they both start with O. And the answer is most people in Oregon weren't satisfied with Ohio. They drove all the way across the rest of the country. That doesn't mean they're satisfied in Oregon either, but they ran into an ocean. Okay? Another O. So you get the gist. So they tend to be a hardy pioneer lot, and they're willing to try stuff. The political process, this is huge, lacks sufficient organizational memory to sustain the principles. Those of us who were part of creating this, well, we had term limits in Oregon in the 90s, which we've now overturned. But term limits were a killer, because everybody who knew bupkis left. And we hadn't had these new legislators who only knew what the Oregon Health Plan, whatever somebody had yelled at them about or what they had read in the paper. That's why you couldn't really hold on to a set of core principles like universal coverage. There were a lot of new legislators who couldn't understand what the employer mandate had to do with Medicaid anyway. Okay? Now, you know, you can pull your hair out over that, because we spent a long time in the 80s building consensus about universality. And then, poof, it's gone. And it's gone just because the players changed. The next thing we learned is that removing enrollees undermines actuarial assumptions. So the state started off about 96 charging low premiums to people who were who were in that 55 to 100% of poverty. So let's means test them. Let's charge people anywhere from $2 to $15 a month to be in the plan, because we had Republicans took control of both houses of the Congress, and they felt that personal responsibilities was good and that people should pay a little bit for this, and they could afford $15 a month. Do you know what charging $15 a month did? To start with, we knew before we did it that collecting the money from them would cost more than $15 per person per month. Right. So why did we do it besides this idea about personal responsibility? We did it because when you charge that premium, poor people will only sign up when they're planning to go to the doctor. That removes well people from the risk pool. But we didn't redo the actuarial assumptions. So the monthly payment rate per member per month was assuming that all these people were in the pool. You take a whole bunch of people who aren't sick out, that assumption is no longer valid for the remaining set. And I'll tell you, if you ever really understand this, you can make a fortune in health insurance. This is how health insurance companies make their money. They make their money by providing coverage to people who don't get sick. Right? So, you know, there's all kinds of strategies that they take to do that. But removing enrollees undermined the actuarial assumption, and it's why the reimbursement rate went down to providers. Because the only way to take care of the remainder set was to pay less out per unit of service, which is what they agreed to not do when we started the plan. And finally, implementing the OHP standard categories reduced benefits and may have actually increased cost. One of my researchers in the health policy research group right now is studying this as a naturalistic experiment. What actually happened to Medicaid per capita cost when we took these people's mental health drugs away? Okay? And we're going to know a lot about that, because that's something she's working on right now. So in 2006, the Oregon Health Services Commission got reconstituted, and we decided to develop a new method and start over and recreate the Oregon Health Plan. And basically, they developed these 9 categories to replace the 17 categories from before. Remember, before I showed you, the #1 item was acute conditions that were fatal if not treated. Notice now that that's moved down to #6. What's the meaning behind the difference between these lists? The chair of this Health Services Commission was the residency director in my department. So we're pretty involved with all this. But the question of, well, what philosophically is going on here? Why does this list look as different as it does? What has changed over this, 15-year period since we started it the first time in 2000, or in 1990 rather? Okay, so we're doing it again in 2006. So here's the way to think about that. And of course, within each of these categories, points are given to individual diagnosis treatment pairs. based on impact on life years saved and suffering and population effects and whether vulnerable populations are affected as a method for ranking things within the 9 categories. Are you with me? Now here's what's interesting from an ethical discussion, and I can tell you from knowing who was on the Health Services Commission that they did not explicitly talk about what I'm going to tell you now. They actually worked through what they thought the priorities ought to be, sort of a priori, just working through these lists. But I'm going to show you some patterns to their decision making which I think are interesting and may represent a little bit of a pathway for health care reform to be discussed. So first, let's look at these list of 9 again, and I want to ask you to, in your mind, which of these services is primarily a public interest versus a private interest? In other words, which of these things would you really, really care about your neighbor having as well as yourself? Maybe you don't want yourself or your neighbor to have inconsequential care. Maybe self-limited conditions. Maybe you want some treatment for a condition that's going to get better anyway, but you probably don't care much about whether your neighbor gets that. You may or may not care about fatal conditions in your neighbor. Okay? It probably doesn't change your life very much if your neighbor dies. But it changes your life a lot if your neighbor is in the emergency department with uncontrolled congestive heart failure, because it drives up health care costs and it clogs up the emergency department. And it definitely messes you up if your neighbor has a sick and disabled baby because of bad maternity care. So I would argue, for me anyway, these top 4 items are kind of public benefit stuff. Okay? Public benefit stuff. Reproductive services include contraception. Okay? So maybe we could argue whether this is right or not. Yeah, let me go back one.
Okay, well, go to your next 4 then, please.
So these might be more public interest and these might be more private interests, okay, or more beneficial to the individual than the community. It's part of what I'm trying to get you to struggle with, and maybe this is way too coarse and not granular enough. You'd have to get down to more individual things within it, but this is something we can talk about when we get to our discussion. I think these are the items that are high cost items, not high cost to the individual, but high cost to society. Okay? In the aggregate, we spend a lot of money on those things. And I think that these are relatively low cost items. Primary care is pretty cheap. Comfort care and self-limited condition care is really pretty cheap. So we've been talking about, well, if you're going to look at this in these 2 dimensions, maybe you could look at high cost and low cost on the y-axis and public benefit and individual benefit on the y-axis. And maybe the thing to do with health reform is to provide social insurance for those things that the whole community benefits from having. Okay? Maybe the high cost private interest stuff we have catastrophic policies for, and maybe out-of-pocket care for low-cost individual benefit things. One way to think about it. We've been talking more and more in our state about carving primary care out of insurance entirely. As a matter of fact, I think it's one of the more creative ideas we have right now, that maybe we will prohibit any health plan from covering primary care. So we're going to set up a non-for-profit government entity that is the single payer for primary care. All health plans have to pay a $25 a month tax for every enrollee into that system. The state puts $25 a month in for Medicaid. The feds put $25 a month in for Medicare. And health insurance no longer covers primary care. This entity is a single payer for primary care. If you're a medical home, the patient can choose you as their family physician or as their medical home. They do that at the end of the year. In January, you then are assigned to that practice, and the practice is paid on a per-month basis to take care of you for the year. If you did this, the patients could change doctors at the end of the year. Primary care practices would not need a billing system. They would save 12% of cost right away if they did that. The second thing is that the primary care practices would know their gross revenue on January 1st for the year to come. And third, Since many of those patients will be holdovers from the previous year, they'll know what the population health burden of that population that's chosen them are, which means they can staff the clinic based on the needs of the people they're serving. That's another idea we're talking about in our legislature right now, about how we might do delivery system reform. The difference between these discussions that we're having now and the Oregon Health Plan is the Oregon Health Plan was about how to decide what was paid for and how it was paid for. It was questions 5 and 6. And now we know we've got to reorganize the delivery system to have cost containment in the model. And so we're talking about the questions 3 and 4 at the beginning of the talk. So now we've got this Oregon Health Fund process, which was passed in June 2007. Well, Oregon is a very civilized state. How civilized is it? It's so civilized that the legislature only meets for 6 months every 2 years. The rest of the time they go the hell home. And we have no laws being passed, if we can help it at all, unless they're called back into special session. So they come into the first 6 months of every odd-numbered year. They're back in session again now, which is why we're talking about all this again. But in 2007, the government created this group of task forces to try to define how the Oregon Health Fund will go back to the idea of universal coverage and perhaps organize the payment system for the whole state differently. Oregon could easily decide to do a single payer system as coming out of this model. The report from the Health Fund Board was pretty unimpressive. And we're now back in a recession again, and there's no way they're going to do anything creative. But in 2011, this may form the basis for ideas that we would do. We created this statewide program to measure the attributes of an integrated medical home. That will pass in this session. We'll create an Oregon Health Fund Board capable of brokering health insurance to the uninsured. In other words, a public purchaser to bargain for all of the uninsured as a group and to get group rates for them. And an integrated Medicaid program with this Oregon Health Fund Board process. I think those things will pass in this legislative session. I want to close, because this has been a personal experience for me. I want to close with another quote from Gail Stevens, Family Medicine is Counterculture, which I quoted him this morning from the same paper, actually. But I think this speaks very well for what it's felt like to me to spend 20 years working on health reform at the state level in Oregon. Dr. Stevens was talking about the first generation, the first 10 years of family medicine as a specialty. Family medicine started in 1969, and so he was writing kind of on the 10-year anniversary of the field. And as one of its founding fathers, he was looking at what had been accomplished in 10 years and trying to decide what to make of it. Okay? And it captures my feelings about this. We've had to settle for less than we hoped for. We hoped for everyone to have access to a personal physician, and we've discovered that not everyone wants one or can utilize a personal physician properly. We hope to produce compassionate physicians, and we've had to settle for producing less cynical ones. We hope to teach continuity of care, but found that there was little time in which to do it. We wanted to educate patients, but found that we ourselves lacked the education to do it. We wanted to integrate the art and science, but seemed to always have to choose one or the other, Dr. Dukas. And finally, perhaps our unfulfilled hopes are less remarkable than that we hoped at all. So my lesson from the Oregon Health Plan is, even if we accomplish nothing, we amuse the daylights out of ourselves. Okay? And you know what? That's not so bad, because we came to work every day believing in something, and we worked really hard at it. I think we learned valuable lessons that we're better off for having learned. I can't tell you we have this problem solved, but we have whacked at it. We've done our best at doing something about it. And if it doesn't get solved, at least I'll be able to live with that. Okay? And I think that's really the point from the quote here. So let's stop. We've got plenty of time for discussion. And thank you for your attention and for listening and for your invitation.
We've had it merged locally to NDVIP, in which a physician is put on a retainer. In one case, Roger was for $1,500 a year, which is an effort to define the number of patients that this particular physician will care for and at the same time remove the enormous load that the physicians can carry. So you reduce the load to like $900 a year, and all the other patients are thrown off on the system. And that's called VIP. That is, presumably, the VIP is the patient. My questions about that. Once you do the math, 900 times 1,500 adds up. But it occurs to me that that might have a certain kind of appeal in a system like this. Pay all the physicians up front a certain amount, and you got the patient load just defined. Has that come into Oregon at all? What sort of reception, and how is that being integrated?
Well, we're doing a fairly...
Summarize the question.
Yeah, okay. So the question he's asking is about VIP or retainer practices or boutique practices that charge patients a monthly fee to be enrolled in the practice, and by doing that are able to take care of a much smaller panel size of patients and deliver care to them in a sort of a more intense way. And it's been termed VIP care. Apparently there's some practices here in Louisville that do that. There are some practices in Oregon that do that too. So we've been experimenting with that in our own practice in Oregon. Our experiment is with uninsured people, charging them $25 a month on a retainer to come to our practice. I have, and part of this has to do with how does innovation happen in healthcare? Well, I think there's a strong cohort of people, many of them in leadership positions in healthcare organizations, that thinks that innovation in healthcare is like innovation in industry. It happens because venture capital chases out good ideas and successful business models make people rich. Medical students ask me all the time, Dr. Saultz, how come dermatologists make twice as much money as family doctors? The answer is because they care more about it, actually. Because it's not hard to make $400,000 a year as a family doctor. You can do stuff like that and you'll do fine. Most of us aren't quite willing to do that. We know that if we all did that, there'd be no hope to get everybody into our practices. We try to take care of the people in town in an accountable way. If you live in a small town, you know, I always joke, family doctors in small towns drive pickup trucks until they retire and then they buy a Lexus. They don't buy a Lexus while they're there, because the patients think that you're haughty if you're driving around in a nice car at their expense. Okay? But financial models for how to pay practices differently, you know, the British pay people exactly the way that I described for this idea of carving out primary care. People choose the practice and they're paid on a per month basis. The idea of pay per performance or medical home payments is something on a per member per month that supplements fee-for-service care. But you know how much primary care really costs? I don't know if you've ever thought about this. Our experiment in Oregon with the uninsured is charging them $25 a month. $25 a month. Can we make money at $25 a month? Okay? He's shaking his head no. I'm doing an experiment right now to find out. I got about 650 people enrolled, and I'm measuring it. My time period is February 1 of 08 to February 1 of 09, and I'm analyzing the data right now. But I'll tell you why I think the answer is yes. 25 times 12 is $300 a year. What's the typical practice size of a family doctor? 2,000 patients. Do you know what 2,000 times 300 is? It's $600,000 a year. If I have a 50% practice overhead, I've just doubled the income of the average family physician at $25 a month, which is less than half of what these people pay for their cell phone, including many of them who are uninsured and poor. So our services actually are pretty cheap as things go. Now that only includes our services. It doesn't include their drugs or their cholesterol test, but it includes what they'd pay me. Wouldn't it be nice? Maybe I should get paid up front. And then everybody else worry about figuring out how to collect money from these people for stuff that they often don't need anyway. Okay? So I think that retainer plans, healthcare reform is probably going to involve a change in the way primary care is paid for. Whether it's carved out the way I described, whether it's a per member per month fee for case management that sits on top of the fee-for-service system, but boutique care is boutique care because it's sold to rich people on top of commercial health insurance. I think one of the more likely health reform scenarios in Oregon is that primary care people all fire all of the insurance companies and do care directly with the patients. Once the patient's deductible is already over $25, what's the difference? Okay, so that could be a vehicle for change. In the absence of meaningful payment reform, I think that will happen in my state in 2 to 3 years, and it will happen almost immediately if Medicare cuts its reimbursement rate. Other questions? Yes, ma'am.
Would you talk about the concept of a medical home? And I want to congratulate you for using health home. I represent nursing.
Uh-huh.
Nursing is certainly interested in the broader term. And also, how do you think that concept will save money? It's not, the research on it does not save money.
Right. So the question is, what about the concept of a medical home versus, on my slide I used the term health home. Actually, the term we're using in Oregon is integrated health home. And it was a product of sausage making, of the political process with people arguing about what word we should use. I was disappointed that patient-centered got removed. Okay, I'm rather fond of patient-centered medical home, but patient-centered health home, integrated health home. You know, this is a topic that I did grand rounds on this morning from 7:30 to 8:30, so we talked about that a lot earlier. The medical home right now is a set of ideas. It's a confluence of 4 principles or 4 elements that I think constitute the best definition of it. So the first element is primary care. It includes all of the things that we know are beneficial to the population in terms of primary care. Okay? The second is chronic care management, which primary care is traditionally done badly, but if you look at the chronic care model that Ed Wagner developed at Group Health or that Kaiser Permanente uses, there's improved performance on chronic disease management when this model is used. The third is patient consumerism, trying to figure out how to make patients confident and happy with the care they're receiving as opposed to frustrated and annoyed by the care they're receiving. And the fourth is information technology and the integration of electronic record systems and electronic data systems within that medical home. Those 4 ideas kind of packaged up is what the medical home will be. Mostly, though, it's a cultural icon that we're using as a metaphor to talk about improved primary care reimbursement in exchange for re-engineering the primary care system. And we're putting enormous energy in my department, an entire whole research program around that, which, like I said, I talked about this morning. I think people get confused when you talk about saving money. Okay? So, does preventive care save money? It depends on what your denominator is. Preventive care probably does not save money. It makes people live longer. Okay, I used to have, I was talking at dinner last night about my friend, former Governor Lamb of Colorado, who used to argue that if everybody stopped smoking, it would increase health care costs in America. That smoking does not increase health care cost. And in fact, if everybody smoked, health care costs would go down. And people would argue with Governor Lamb, and he would say, look, if you don't smoke, you live 5 years longer than if you do, and it costs a hell of a lot to take care of somebody for 5 years. And everybody's sick at the end of their life anyway, unless you're hit by a bus. So his point is, the longer you live, the more it costs. And dying quick is good if you want to save money. Okay?
Smoke them if you got them.
Smoke them if you got them. So the point is, we know that primary care delivered well lowers population health care costs. It lowers per capita costs across the population. It delivers better value, better outcomes for the dollar. I think there's conclusive proof of that. But whether or not, doing primary care really well lowers lifetime health care costs, that's a harder question. Other question? Yes, ma'am.
From a
community health perspective, because that's mine. I'm not in this league, but I'm here because I teach in community health and in health education for a teacher prep program. But I always tell my community health students that I'd be interested to see if you will have an emphasis in mental west of health educators, because the community health educators that I'm trying my best to prepare have a more global understanding. But also what I'm seeing from the U of L perspective is I'm starting to get a lot of students that start out in nursing, so they're not either hacking it or enjoying it in nursing and clinical. So they're coming to me, and it's kind of funny because that was my own kind of track. And so I'm thinking, how can health educators help out with primary care? Because I've always said that you have all these patients that you have to see, but since a part of that is chronic disease management, then why not hire a diabetes management specialist? Why not hire? It's cheap. I mean, we're talking 35, at least here in the city of Louisville, we're talking, my students would be thrilled with a $32,000 to $35,000 to $38,000 job. So I just wanted to see your perspective on prevention in terms of community health educators, and what does it look like in terms of market in the Northwest? Here, I don't see that.
Right. Well, I don't think that the market may be a little bit better in the Northwest. I don't think that its quantum level's better in the Northwest. So the question I was asked was, what about community health educators? It seems like community health educators ought to be a really valuable addition to the primary care team. We have a program to train them here in Louisville, but there doesn't seem to be gobs of practices that are trying to hire them. Why is that, and what will it take to change it? Have I got the question okay? Okay, so first of all, I'm going to give you the cynical real answer to your question about the past, and then I'm going to try to give you the answer that I think will fit with the future. So in the past, the last thing I want to be is really, really good at diabetes care. Okay? Now let me say that again. From an economic point of view, the last thing I want to be is good at diabetes care, because it takes me forever to see a diabetic, and I get paid the same amount for the visit. And frankly, diabetics clog up my office, and they mess up my outcomes. I'd rather have a lot. They all get sick. They have a lot of complications to them, and it's much more cost effective for me to take care of well people and people with acute minor illnesses, and to do that fast, because I can turn a much better profit per unit time doing that. And I get the crap hassled out of me every time I have a diabetic, because their health plan wants me to fill out 150 forms. They change the drug formulary every month. And so a lot like hospitals are trying to get out of taking care of poor people, the fact is a lot of primary care practices aren't that enthused about embracing doing chronic illness care well, because it feels like a trap you're stepping into, right? And I think from an economic sense, it is kind of like that. I am not paid more for doing that well. And in fact, it takes me more time. Where would I get the money to hire you? Because I can't bill for your services as an educator, right? Why is that? Why is it that I can't do that? Well, because the health plan might hire you and have you call my patients on the telephone and tell them a whole bunch of stuff that I don't know what you're telling them. They do that. I love it when they do that. It's great. What I'll usually say is, well, then at 2 o'clock in the morning on Saturday, why don't you call the damn health plan and tell them about your foot hurting? I mean, that's ridiculous. Instead of routing that money through the system to do the care, they have no particular confidence that we would do it well in primary care, and maybe they're right to be cynical about that. How will this change in the future? Well, if we go to a case managed fee, if we made it profitable for me to care for chronic illnesses, and if I was allowed to be innovative in how I do that, you can take a look at single payer systems around the country and see what the future will look like at Group Health Cooperative, at Kaiser Permanente, in the VA health system, in Indian Health Service clinics. Those are all right here in the United States. What do they have in common? A single payer system where the risk is held by the same entity that owns the delivery system. What do? Well, they do creative things like group visits. Do you know something? If you get a bunch of diabetics together and have them get to know each other, they call each other. They do. We've found in our practice there is an enormous value to group prenatal visits. Some of the closest friends that my wife and daughter have in their lives are people that they met when they were going through pregnancy. You have a child, they go to the same daycare center. You glom on and become friends with these people. So what if you took everybody that was due during the first quarter of 2009, you made a prenatal cohort of them, and you had them come in once a month as a group to use your waiting room like a classroom with a health educator to talk about not only prenatal care but parenting with those women and their partners. Imagine what a transcendently valuable thing that could be. But there's no payment for that unless you charge them for the class. So I think that will be an integral part of medical homes in the future. I absolutely believe that. If you have a system like the British have, which is this monthly payment that we were talking about, so in England you pick your doctor, you're with that doctor for the year, you're going to know, for example, what the prevalent problems in the clinic are. You're going to know all of your diabetics. Now I know that there aren't a lot of practices in this city that have electronic health records yet. And how many of you are family doctors or primary care physicians? So not very many. If you were to go to a family doctor's office here in Louisville that has paper medical records, and I were to say, okay, you're now my diabetic educator, right? I want to hire you to do that. Go in there and figure out who all the diabetics are and call them all on the phone. You'd be faced with a room full of charts filed in a numerical order. You'd have to pull every one of them out, or you'd have to go to the billing system and say who had ICD-9 code 250.XX sent to an insurance company. It would be, you'd have to pull out every record to get the phone numbers. In my practice, I can not only tell you every one of them by name, I can tell you when their most recent hemoglobin A1C was done, which ones are over 7, which ones are over 8, which ones are over 9, how many of them have microalbumin in their urine, and when they've all last been to the ophthalmologist. It's right there. That's a keystroke for me. When I'm able to manage information like that, I can then start managing cohorts or populations of people. And that's where the educator helps me. You don't help me so much one-on-one. You help me hugely when I can get groups of people together and meet educational goals in a cost-effective way. And that will be part of the future, I'm sure. So hang in there.
John, I think we have to close.
Okay?
Thank you very much. Thank you. We have to go to our next presentation.